Good day, everybody. I'm Anna Plotkin, Director of Continuous Professional Development at the University of Toronto, and myself and Dr. Nicolina Churchin from the William Osler Health Sciences Center, we would like to welcome you to the breast community of interest, and it's our last rounds for this year. We want to thank everybody who submitted the presentation, and hopefully we'll have enough time to go through all the presentations. And as you know, the rounds are 2 hours. Just to remind everybody, at the end of the year, you will be getting your CME certificate, so you can submit your Royal College hours, as those rounds are all accredited. I would like to introduce our moderators, Dr. Sharon Norfolk-Moses from Sunnybrook Health Sciences Center and Dr. Anna Marie Mulligan. Hi, Anna Marie from University Health Network. We have a special guest today, Dr. Fang-I Lu, who will be giving a very interesting presentation, and she'll also present some cases relevant to breast pathology. Fang, the floor is yours.
Hi, hello. I'll just share my screen. Hopefully it will work. Okay. I think you're supposed to see this one. Do you see the presenter mode screen?
Yes.
Okay, perfect. Okay, let me just go to the right screen for me as well. I think I'm supposed to have this one. Okay, so sorry, I'm in the presenter mode, so I cannot see any questions or comments. So if you have anything, please just unmute yourself and talk, because I will not be able to see your hands or anything like that. Okay. Okay, so
I think I'll be
yes?
monitoring chat,
okay,
so
perfect.
I'll help you out if there are any questions.
Okay, perfect. So yeah, so today I'm going to talk about a topic that I've been working on for the last couple of years, which is a pathologic assessment of breast cancer specimen post-neoadjuvant therapy. I presented this talk at a couple of local and national conferences, so it might not be the first time that you hear about this, but hopefully, especially for people who haven't heard about it, you might find it interesting. And I'm also presenting a little bit of new data that we got that we presented at the CAP annual meeting this year. So I have no conflicts of interest to declare. So today I'm going to talk about a national consensus approach that I and a group of pathologists from across Canada developed, specifically to assess a breast specimen after neoadjuvant therapy. And I'm going to show you why I think it's high time that we have some sort of standardization in this topic. Then I'm going to go over 4 cases ranging from the banal usual case to kind of more challenging scenario. So my interest in this area started just with my clinical practice, just seeing the wide variety of practice in this area. And in 2018, I conducted a pan-Canadian survey involving both pathologists and pathologist assistants from across Canada, and also involving people who practice in the academic center as well as in a community setting. And I think there's even a couple people from private lab as well. And then confirming my suspicion, there's actually a significant proportion of pathologists and pathologist assistants who are not comfortable in grossing and reporting these kind of specimens. When I also asked questions about specific aspects of the practice, and then not surprisingly, I also found wide differences in practice. So in terms of like pre-op tumor and lymph node localization, so whether it was done or how it was done, and also whether frozen section of the lymph nodes were performed on cases post-neoadjuvant therapy with tumor with a positive lymph node before the chemo, as well as in the way that specimen is grossed. So first of all, whether people use grossing map or grossing diagram, how extensively people sample the tumor and measure the tumor size. And then also in the specimen reporting, so probably not surprise to all of you, but 52% of the pathologists did not use residual cancer burden index, and many don't even report features that are necessary to calculate the residual cancer burden index. And shockingly, at least in the survey population, only 34% got the correct diagnosis of complete pathologic response. Most of them wrongly call cases with lymphovascular invasion complete pathologic response, or cases with DCIS as not complete pathologic response. And also, I also look at like the practice and experience of the pathologists who are surveyed. And there's really no difference between academic versus community practice, and also no difference with varying lengths of practice. So definitely it's a problem for all of us. So because of this, I work with, as I mentioned, I work with a group of pathologists really from across Canada, from Halifax to Vancouver, to develop a national consensus approach, because I want to make sure that, you know, the approach is feasible sort of basically across Canada, and that is feasible across Canada, yeah. And our recommendation was based on the one that's developed by an international collaboration group called Big NAV BCG, that was actually published in Modern Pathology all the way back to 2015. Originally was used for the research setting, but more and more is being used on the clinical setting as well. And our recommendation has recently being accepted by CAP, and as you can see here, you can find it on their guideline webpage. So I'm just going to talk a little bit about what we recommended. So in terms of Ggrossing, so the first step of Ggrossing is to identify tumor, and this starts with reading carefully the pre-neoadjuvant therapy radiology report to identify the number, location, and sizes of tumor foci. Because as we know, tumor after neoadjuvant therapy can be very subtle and hard to identify grossly. Then the next step is to thinly slice breast every 5 to 10 millimeters to identify the tumor. And if no tumor is grossly identified, then hopefully your clinician place a biopsy clip in the tumor and plus minus in the lymph node that was biopsied, because this is very helpful so that you can x-ray the specimen to identify the tumor, or at least where the tumor was pre-chemo. And then once the tumor is identified, you should measure the size of all tumor foci in 3 dimensions, because for residual cancer burden index calculation, they require the 2 largest dimensions. So in terms of block selection, if a tumor is identified, then it's much simpler. You need to submit at least 5 blocks from the largest cross-section of the tumor to assess average tumor cellularity. For a small tumor, you know, this may even mean, like say something less than 5 centimeters. This may even mean that you submit the tumor in total. If no tumor is identified, you actually need to do more extensive sampling of the fibrotic breast tissue around the biopsy clip and in the location of the tumor pre-neoadjuvant therapy if biopsy clip was not used. And we recommend at least 1 to 2 blocks per centimeter of the tumor size pre-neoadjuvant therapy. So if the tumor was say 6 centimeter pre-chemo, then you need to submit between 6 to 12 blocks of the tumor. And then all the blocks should be mapped on the specimen photograph or schematic diagram. And this is very helpful to assess the tumor size as well as the tumor focality. So in terms of reporting, we recommend including all the information that are required to define a complete pathologic response. And if the tumor did not achieve complete pathologic response, then all the information that are required as per AJCC, as well as for RCB calculation. And we actually did not sort of, we actually leave the calculation of RCB index and RCB class optional, but you should provide the features that's needed for RCB calculation. And we recommend the use of synoptic report to make sure that all the important information are included. And actually at Sunnybrook, we recently recently updated our synoptic report so that now there's a section that allows us to input the feature needed to calculate RCB index, as well as the actual RCB index number and RCB class if you decide to calculate it. But that section, the data from that section is not transmitted to CCO. It's just kept in-house. Now, if no tumor is identified, it's very important to identify and report in your final diagnosis that you've seen definite treatment-related change or biopsy site change in the breast parenchyma and the lymph nodes. And I cannot emphasize enough. The use of biopsy clip is very helpful in this scenario to make sure that you sample the correct area. And then in this in a section that show these kind of changes, it's very I recommend you to go on high power to do a very careful microscopic examination, because there's very little residual tumor. Even myself, if I look at the slides at 7 p.m., I often miss it at the first go. So I definitely focus on the slides that show these kind of treatment or biopsy site change and really go under at least at the 20x, maybe even higher power. And sometimes, if necessary, I might do deeper sections or flip the block and use keratin stain in this block to help me identify minute amount of residual tumor. Especially if on your first set of slides, you don't see definite treatment or biopsy site change, you should think about going back to the bucket and sample additional area where the tumor was pre-chemo. So when I presented, when we circulated our recommendations nationally for feedback, as well as the feedback that I got from pathologists that sent me email, people are very worried about using the residual cancer burden index. First of all, in terms of its reproducibility, as well as the workload, increased workload that's associated with this. So in terms of the reproducibility, there's actually two published studies on this. So the first one, this one published in Histopathology, was done by Dr. Simon, who developed the residual cancer burden index. And then this second one was an independent study by a group of pathologists in UK. And reassuringly, both studies found that there's a very high concordance amongst the study pathologists in terms of the contiguous and categorical RCB, so the RCB index number and the RCB class. And I should say that like none of the study pathologists receive any sort of extra like coaching on doing the RCB index. All they did was they follow the publicly available RCB calculation guide that's available on the MD Anderson website. And then in the study by Dr. Simon's group, they also found that the RCB, as assessed by the participating pathologists, accurately predict long-term recurrence-free and overall survival. So definitely another evidence that the pathologist must be doing something right. But then when they look at like individual RCB variable, they found that there is less concordance among the pathologists, especially for percent tumor cellularity and tumor bed size. And this is also definitely the most challenging area, but it actually doesn't matter very much because the RCB index calculation, they use so many variables that if you have a little bit of difference in terms of, one call 20%, the other one call like 30%, and the tumor size is slightly different, it actually won't change the contiguous and categorical RCB so much. So in terms of the workload, the pathologists who were involved in the development of the recommendations also did a little study earlier this year. So the 8 of us from 4 sites across Canada, we assessed breast cancer resection specimen after neoadjuvant therapy using the guideline that we developed. And then each of us will assess the workload for each case using both the time spent in minutes as well as the CAP's workload model, which is as per L4E units. So each L4E unit is equivalent to about 10-minute time spent. And so in total, 34 cases were assessed with variable degree of case complexity, ranging from PCR to a complex residual tumor case. And overall, as you can see here, there is no significant difference in the workload assessed using time spent versus using the L4E model. So if your hospital is using the L4E workload assessment, then your workload is definitely accurately captured with that tool. Okay, And considering the L4E was developed for cases that did not receive neoadjuvant therapy, you can kind of postulate that probably overall the workload of cases that got neoadjuvant versus those that did not get neoadjuvant are fairly similar. However, when we look at case complexity, you can definitely see that for sure you will be spending a lot more time on the complex residual cancer case than cases with PCR. And L4E definitely sort of is more generous for PCR case, but maybe doesn't sufficiently capture the workload for complex residual cancer case. But as I repeat, overall, L4E should still fairly well capture the time you spend on all the case all combined. And I should say that I had to exclude the data from pathologist 1. So he used digital pathology only, and he also has a transcriptionist who type out his report. And he really spends significantly less time than all of us combined. So on average, he spends 36.1 minutes per case, whereas the rest of us is 135.9 minutes. So, I mean, it's just a small number, like the n of 1 with not that many cases. So it's hard to say something to say something meaningful about it, but maybe this is kind of an argument for the efficiency that you can gain from using digital pathology and maybe a transcriptionist. So any question about the first part?
I don't see any questions, Fang. Just a reminder to everybody, if you have any questions, please submit them in the chat box. If you want to be unmuted, just raise your hand and we'll unmute you to ask the question.
Okay. Okay, so I will just keep going. So I have 4 cases that I'd like to present today, all sort of highlighting different issue. The first case is sort of a straightforward case just to illustrate how one should assess tumor cellularity. So this is a case of a 57-year-old female with a right breast mass that has skin involvement that measure up to 67 millimeter, and there is no other mass or suspicious vascular lymph node identified. So the biopsy of this mass showed intermediate grade invasive ductal carcinoma that's a hormone receptor positive or HER2 negative. So because the tumor is large and involves skin, she ended up getting a neoadjuvant chemo and letrozole. And because the surgeon planned to do a lumpectomy post chemo, a clip was placed in the breast mass. And unfortunately, the imaging study post chemo showed minimal tumor response. So this is the X-ray of the lumpectomy specimen just to show the presence of the biopsy clip, as well as the localization C here that we use, the radioactive localization C here that we use. And then, so this is a gross image of the specimen. So as you can see here, there's a fibrotic firm area, and the biopsy clip and biopsy seeds were also identified in this firm area, so highlighting by the circle and the arrow. So the first question is, how much of the tumor would you submit? So there's different way you can submit this specimen, and there's no right or wrong answer, but there's definitely more or less efficient way of doing things. So the most efficient way will be submitting at least 5 blocks from the largest cross-section of the tumor as we recommended in our guideline, and then going all the way to submit the whole lumpectomy. So in this case, we submit the largest cross-section is medial lateral, as most tumor is. And then so we basically submit 5 sections from the medial lateral dimension, as well as a section flanking the tumor and the closest resection margin. So this is an image of a representative slice from the residual tumor. So as you can see, a lot of this tumor shows like very fibrotic breast stroma consistent with treatment-related change. But then you can definitely see some scattered tumor here, 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 and here as well. So just want to kind of show higher power of these 3 areas. So you can see in this first area, cellularity is actually sort of fairly high, maybe about like 30%. And then the second area is a little less cellular. And the third area, really you have very little residual tumor that's probably will be very hard to see unless you look at it under high magnification. So what is the cellularity of the residual tumor on this slide? So when if you only focus on the area with high cellularity, so the first circle, right? You might say, oh, it's like 30%. But then for RCB index calculation, they were talking about like the cellularity of the entire tumor. And then the best way that to do this is to circle out the contour of the tumor, like what I'm doing here with the blue line, and then really look at it under low power, and then compare the cellularity within this circled area to the diagram, schematic diagram that's provided by the RCB index calculation guide. And this is kind of mathematically generated diagram. So you can see if you kind of compare this blue circle area, it's probably more similar to like a cellularity of like 5 to 10%. Now, if at the beginning, to this day, if I don't do this, sometimes I will overestimate tumor cellularity for sure. And I also just want to highlight the different kind of tumor treatment-related change that you can see, because it's very important to recognize the treatment-related change to make sure that you sample the correct area. And the treatment-related change can range from very cellular, like this one on the left top corner here, where it's sort of a lot of lymphohistiocytic infiltrates, depends on a lot of eosinophil as well, and maybe a little bit of hemosiderin, as well as a change like fat necrosis, to a kind of a very fibrotic area with maybe kind of fairly reactive looking stromal cells. In both area, when you have very minimal residual tumor, the use of keratin can be very helpful in identify minute residual carcinoma amongst all the inflammatory cell, or to differentiate like minimal residual carcinoma from reactive stromal cells. So unfortunately, the sentinel lymph node does show, two of the sentinel lymph node does show a residual tumor, and the largest one is this one, which measures 6 millimeter with you can see here extranodal extension, and the morphology of the metastasis is very similar to her primary tumor in the breast. The second positive node is a little bit more tricky in terms of assessing the size of the metastasis. So literally, you have this sort of area with treatment-related change, with like fibrosis, inflammatory cells, and histiocytes, but then scattered within it, and it's proven by keratin. There's a couple of like scatter cell, like here and here and here and here. So literally altogether, not more than 5 to 10 cells. So what's the size of the lymph node metastasis, right? So if you assess using the HSCC, then this is definitely isolated tumor cell. On the other hand, for RCB index, they consider all the scattered foci within treatment-related change to be part of the single focus. So in that case, the size can be up to 2.1 millimeter, because as you can see here, the distance between the two cluster is up to 2.1 millimeter. So, which is a macro metastasis. So this is sort of a more drastic case showing how the size measurement can differ between HSCC and the RCB. So thankfully in this case, it did not matter because the largest metastasis was actually the first lymph node that I showed, which whether you do HSCC or RCB way, you will end up with a macro metastasis about 6 millimeter in size. So this is the final diagnosis for this case. Okay, so any question about the first case?
I think there is a question. I'll just read it to you.
Okay.
First of all, I answered that question, but maybe you can also confirm. Did you publish the data on the workload assessment?
So I haven't published the data. I mean, we just did it as an abstract. We were thinking like probably if we want to publish data, we probably need to kind of gather more cases. Yeah, so that's sort of on the pipeline. We need to probably gather more cases, and ideally we would do the workload assessment with cases that's not treated with neoadjuvant chemo as well. But then that might be a little bit challenging because the case complexity could be different. And also like for cases that treated with neoadjuvant chemo, you know, another way to do it is do with RCB calculation without the RCB calculation. But then again, that's also a little bit challenging to do. So we're still kind of thinking about how to do this study. Definitely needs more case number, but maybe different methodology as well.
Okay, thank you. And another question, does the cellularity indicate the proportion of the tumor cells to all other cells, like inflammatory cells, fibroblasts, adipocytes?
It's basically the cellularity in that area. So it's not a proportion of the cells, it's basically the whole area. So that's why, so basically, let me just go back a little. So literally, like if you look at the schematic diagram, right? So they calculate that like these 5% cellularity, it occupies about 5% of this circle space. So it's nothing to do with cells. It has to do with the space, the area. Does that make sense?
I don't see anything.
Okay.
Reply. If we will get it, I'll let you know.
Okay, cool. Okay, so the second case is a little bit more challenging. So it's a 54 years old female that has a dominant mass at the 5 o'clock area plus multiple indeterminate masses all on MRI all throughout the lower half of the breast. And the biopsy of this dominant mass at 5 o'clock show an intermediate grade invasive ductal carcinoma with apocrine that's not surprisingly triple negative. And she also has a positive axillary lymph nodes by FNA. So because the surgeon planned to do a mastectomy and axillary dissection, they didn't place any clip in the breast or in the lymph nodes. And then she got the neoadjuvant chemo. And the imaging post-chemo showed minimal tumor response in the breast and in the axilla. This is a gross image of her breast specimen. And there is no dominant mass, as you can see here, but you can see sort of vague fibrotic area, sort of a little bit all over in the lower half of the breast specimen, of the mastectomy specimen. So again, how much of the specimen would you sample? So you can say that, okay, I'm going to sample all the fibrotic area, but that'll probably generate many blocks considering it's a pretty big breast specimen. Or you can kind of be more efficient and say, okay, I'm just going to target the fibrotic area in the lower half because that's where her tumor was before the chemo. And that's exactly what we did. We focused the Ggrossing on the fibrotic area in the lower half. Oh, and I should say that in this large mastectomy, we were able to sample within 16 block. And in general, I would say our mastectomy, post-neoadjuvant or not, we usually can sample it in less than 20 blocks. So this is a representative sections of the fibrotic area from the lower half. And actually, most of the tumor is residual DCIS with a little bit of invasive here that's circled in red. So this is sort of higher magnification showing the invasive carcinoma on the left and then in situ on the right. And you can see here both are high grade with apocrine feature. So what's the cellularity of the residual tumor on this slide? So the RCB index actually recommend assessing the cellularity of both invasive and in situ carcinoma. So in this case, you will be circling out the area with both the invasive and in situ carcinoma, and then assess the cellularity within this blue circle, right? And then that would actually be kind of similar to like, if you compare with a schematic diagram, will give you a cellularity of say 20 to 30%. However, don't worry. If you say, oh, well, but then her invasive is so small, maybe this you are overestimating. You kind of overestimate the RCB index. But then, even though the tumor size will be large because you include DCIS, and the cellularity will be high because you include the DCIS. Once you say that like 90% of the tumor is DCIS and only 10% is invasive, if you enter that data, those variable in the calculator, you will see that the number just drop once the calculator does take into account that most of the tumor is DCIS. But unfortunately, she still has a very big lymph node metastasis up to 24 millimeter, and then with sort of very similar high-grade apocrine morphology. So this is her her final diagnosis with the RCV calculation. Any question about that case? So that case was just to highlight what do you do when you have a case with sort of extensive DCIS and a little bit of invasive carcinoma. Okay, so I'm just going to move on to the third case. Yes?
Can I ask you a question?
Yeah.
So have you compared AI or digital scan slide calculation of RCB to eyeballing calculation with the aid of percentage images?
So Sharon is probably the expert in this because that's sort of her area of interest. But Sharon, do you want to say something? I don't know if Sharon, sorry, I cannot see. I don't know if Sharon.
She's here.
Oh.
So yeah, Sharon can talk.
Okay.
Not sure. Okay, I'll ask you after you answer.
You can talk to me. You can maybe
defer to her.
Yeah, she's really that's her area of research. So I don't want to talk for her kind of thing. Yeah.
Okay, and then there is another question. What if the DCIS is not located within the area of typical of tumor regression? In the adjacent section, for example, do you include it for tumor bed calculation?
Then I wouldn't include it. I wouldn't include it. So basically, if you did not include, if the DCIS is away from the invasive and then you are doing the tumor size for that invasive area only, then the DCIS that's sort of far away from it, you don't include. Okay.
Yeah, thank you.
Okay. So the third case, I'm just going to show the importance, basically is to show the importance of having the biopsy clip and the biopsy site change. So this is a patient, 53-year-old female with a 30 millimeter tumor that is ERPR negative and HER2 positive and high grade. So one of those that we expect will have a very good response to chemo. And lymph node biopsy was negative. So because lumpectomy was planned, she got a clip placed in the breast mass before chemo. And MRI post-chemo actually shows no residual breast cancer, consistent with complete imaging response. However, study have shown that like MRI is only about 75% accurate in predicting complete pathologic response. So you know, you have to take the MRI complete imaging response with a grain of salt. So she went on to get a wire localized lumpectomy and sentinel lymph node biopsy. So this is a specimen X-ray to show the wire, and then as well as the biopsy clip. And you can see this clip is sort of, ideally you will want this to be in the middle of the specimen rather than at the edge. And then this is a gross specimen. So just like that X-ray, specimen X-ray, the clip was identified kind of at the edge, so on slide 7, which is not ideal because then you kind of start to worry. So did the surgeon adequately remove the area of the tumor? So again, the question is how much of the specimen would you sample? So the more efficient way will be submitting the fibrotic tissue around the biopsy clip. But some people will say, it's a small specimen, let's submit it in total. And our recommendation is A, because we kind of recommend for a more efficient way of sampling. So that was what was done on the first goal. So the first goal, we just definitely focus on the fibrotic area near the biopsy clip. But then as you can see here, we have to go back to submit a second round, and which end up generating like 28 slides altogether for this pretty small specimen. And you can see why we have to do that. So this is a section from where the biopsy clip was. So you can see here, you have like this big hole that's left by the biopsy clip that we removed. And then with some biopsy site change at the edge. But then where is the treatment related change? So you can say, okay, the breast parenchyma here is kind of fibrotic with some lymphocytic infiltrate and some atrophic lobule, but I hope you agree with me, it's really not a very clear-cut treatment-related change. Like you wouldn't say this as you wouldn't call this a tumor bed with confidence. However, we do have very good biopsy site change right around the biopsy cliff, as you can see here with fine necrosis, inflammation, hemorrhage, and hemosiderin. So that's why you can see why we have to go back for a second round, because we just didn't feel that there is very good treatment-related change, even though there is biopsy cliff and biopsy site change. So in the end, we didn't find anything after very extensive sampling. And because we were able to see biopsy cliff and biopsy site, we end up calling this a complete pathologic response. Without that clip and the biopsy site, we might tell the surgeon that we are not sure that the surgeon removed the area of the tumor, and so that might mean that the patient might have to get additional surgery, just because there is no biopsy clip. Okay, so I hope that case is sort of again another more drastic case, just to show the importance of the biopsy clip placement. So I'm going to go on to the last case, which is sort of a case with multifocal tumor. So this,
I think maybe let's answer a question. There are two questions.
Okay.
In the area of treatment-related fibrosis reaches margins, not the tumor, do you report it, and do the surgeon go back? That's the first question. And second question, also for residual microinvasion only, would the tumulus cellularity be 100%?
Yeah, so the first question is, so if you see definite treatment-related change at the margin, like not definite treatment-related change, not like something iffy like the one I just showed before, but like definite treatment-related change, then yeah, we do recommend that you report that, so that the surgeon, if they want, they can go back and re-excise the specimen, for sure. And then as for the second question, so yeah, so micrometastasis, yeah, you could report the cellularity as 100%.
Microinvasion.
Yeah, but then once you do the RCP index, because the size is so small, it will. There's actually two ways of doing the microinvasion case. So if there's a background of DCIS, you could, that case illustrates, you could do the whole DCIS with the invasive, do the cellularity, size of the DCIS plus the microinvasion and the cellularity of, I guess, mostly DCIS. And then say that, the DCIS represent 99.9% of the tumor. Or you can say that, okay, the DCIS is sort of pretty far away from the invasive, which is very small. And then just measure the size of the microinvasion and then say the cellularity is 100%. Either way, both of them would generate very low RCB index. I have tried that, and I have tried calculating both way, and both of them generate very low RCB index. Okay.
Perfect. Yes, and there is another question. If there is no residual invasive carcinoma and only LVI, how do you measure tumor bed size and cellularity?
So in the LVI, so first of all, that's a very rare case, and so I highly recommend you to kind of do some endothelial cell marker, do additional sections, and especially if there's treatment-related change in the lymph nodes, just do keratin, just to make sure that there's no minimal residual tumor, because just pure LVI is very, very rare. However, we don't think that in case with pure LVI, we don't think RCB index is it's a very good way of assessing the patient's risk, because there's a study that shows that cases with only LVI or predominantly LVI, their prognosis after neoadjuvant chemo, their prognosis is actually worse than patients who did not have LVI after neoadjuvant chemo. Okay, so that's been shown by multiple studies. And then RCB index was never designed to sort of take into account, they did not take into LVI when they developed the RCB index. So for those cases with only residual LVI, if you do RCB, I can guarantee you're gonna get a very, very low number, RCB class, which probably may not represent the patient's outcome, which will be, because you'll get a very low RCB class, but then the risk is probably not that low. Okay, so in that case, so basically with pure LVI, we don't recommend doing RCB. And it's very important to mention that there's residual LVI, and then say maybe study have shown that the outcome is not so good, so that clinician is aware.
Thank
you. Okay, so the last case, as I mentioned, is a multifocal case. With one tumor at the 8 o'clock, measuring 3.5 centimeter, another one at 4 o'clock. And then the biopsy of the 8 o'clock shows low-grade invasive mammary carcinoma, and the 4 o'clock one shows low-grade invasive ductal carcinoma. And both of them are ER/PR positive, HER2 negative. Usually this kind of case wouldn't get neoadjuvant chemo, but unfortunately her axillary lymph nodes FNA is also positive for carcinoma. So in the end, they decide to go for neoadjuvant chemo, followed by mastectomy and sentinel lymph node biopsy. And because sentinel lymph node biopsy was planned, a clip was placed in a positive node. So this is the mastectomy specimen. So we found the 8 o'clock tumor in slice 4 and the 5. So in block 1, 2, and the 10. And then the 4 o'clock tumor, we found it in the slice 9 and the 10. So block 16 and 17. And so because both tumors were pretty small, we pretty much submitted in total, and we also submit fibrotic breast tissue in between these two foci in order to demonstrate the multifocality. Okay, so this is an image from the 8 o'clock tumor on low power examination. So you can see it has a very sort of pretty much solid growth pattern. This is a higher power demonstrating the intermediate to high nuclear grade. So this one end up getting called intermediate grade invasive ductal carcinoma. On the other hand, the 4 o'clock tumor you can see on this low power is has a very tubular growth pattern and very low nuclear grade. I would call this a nuclear grade of 1. So this is a well-differentiated invasive ductal carcinoma. She also has a still fairly significant residual lymph node metastasis, as you can see here, spanning 11 millimeter, with the morphology that's more similar to the intermediate grade invasive ductal carcinoma. So how would you report this case that has sort of 2 tumor foci? So the first thing is you have to make sure that the tumor is truly multifocal, because oftentimes tumor after neoadjuvant chemotherapy, they shrink it in a patchy fashion, so-called like Swiss cheese. So you get like multiple cluster of tumor within an area of like treatment-related change. So a tumor that was unifocal pre-neoadjuvant chemo can be mistakenly called multifocal post-chemo because of this kind of patchy tumor shrinkage pattern. So to call something truly multifocal, so I would say there's like 3 criteria. First is that ideally it will be called multifocal pre-neoadjuvant therapy on imaging. And then secondly is if you have different morphology, then you can also call it multifocal. And then thirdly is if post-neoadjuvant chemotherapy, you are able to demonstrate benign breast parenchyma between the 2 foci, then you can also call that multifocal. So short of that, I would say do not call something multifocal unless you have very good evidence. And then so the tumor, so in this case we have 2 tumors. So the 8 o'clock one was moderately differentiated with lobular growth pattern up to 26 millimeter, but then the cellularity is only 3%, with DCIs accounting for 70% of the tumor. So whereas the one in the 4 o'clock is a lower grade tumor and only 6 millimeter, but then the average cellularity is actually higher, with most of it being invasive, DCIs being only 5%. And she also has 3 out of 5 sentinel lymph node positive macrometastasis. So how do you report this kind of case? Do you report the feature of tumor 1 or tumor 2? So both AJCC and RCB recommend reporting the feature of the largest focus or residual invasive carcinoma, because that will usually give you the highest RCB score. However, this is a little bit more controversial if, let's say, the smaller tumor is more biologically aggressive. So for instance, it has higher grade or it's HER2 positive or triple negative. Then in that case, that tumor, even though it's smaller, might actually be the one driving the prognosis. So when you have like 2 tumors that sort of fairly similar morphology and fairly similar biomarker profile, then definitely use the larger tumor to do your AJCC and do your RCB calculation. But if you have 2 tumors where the smaller one actually have some feature that could make it more biologically aggressive, then I'll recommend maybe do definitely at least the RCB, do the calculation for both. Report the feature for RCP index and calculate RCP index for both tumor. For HSCC, I think you still should use the largest and not the smallest, but I'm not sure that will actually be accurately predicting the patient's prognosis, to be honest. So those are the 4 cases that I want to show. So I hope I highlights the importance of standardizing the pathologic assessment, processing and assessment and reporting post-neoadjuvant therapy for ensuring accurate prognostication. And then this is done through very thorough sampling examination of the tumor in the breast and the nodes. And I cannot highlight enough the importance of biopsy clip, and as well as reporting the element needed to assess PCR, AJCC, and the RCB. Okay, that's it for me.
Thank you so much, Fang. I just want to mention that Fang actually took this as her targeted interest, and she was presenting at multiple conferences. She probably visited some of the hospitals in Ontario, and she published quite extensively on this topic, and she has a lot of interest in this area. So she's the person to go in many, many difficult cases. Fang will continue with questions. Are sections adjacent to infiltrative tumor, which only show LVI, included in the tumor bed and calculation of the tumor cellularity?
So if you also have invasive plus LVI, yeah, I will probably, that's a little bit challenging. So if the LVI is very far from the tumor, I probably wouldn't include it in the tumor bed size and the cellularity calculation if it's very far, because I think that will sort of overestimate the tumor size. Yeah, and then in that case, it's super important to mention the presence of LVI, because again, the prognosis may be worse than what you assess based on the tumor size, the cellularity. Yeah.
Okay, there is another question. Have you received the request for reporting Ki-67 in post-chemo patients for abemaciclib adjuvant treatment? If so, what is the guideline? Do you report it based on hotspots?
We don't actually currently report the Ki-67, so I can't say too much about it. Our center, we don't currently do it.
Okay. Another question, how do clinical management differ between different RCP classes?
So right now, so study, because I didn't want to take out too much time, so I didn't show the survival data with a different RCP class, but definitely RCP0, well, RCP0 is complete pathology response, but even RCP1 has fairly good prognosis. And I have definitely seen sort of cases where with RCP1, they sort of omit, for instance, a radiation post-mastectomy if it's only RCP1 with very little residual tumor and no lymph node metastasis, for instance. But that's sort of, that's also an evolving area. The clinical management of based on the RCP is also still an evolving area. That being said, I still think there is a value in providing RCP, just because I personally found it to be a much better way of describing the tumor post-neoadjuvant chemo comparing to AJCC. Like I've really found like AJCC, when it's just reporting like the size, you can have a same size tumor, one has like 80% residual tumor and one with like 0.1% residual tumor, but then both of them will end up getting the same AJCC number. I just don't think that's right. I just found that RCP with the introduction of the cellularity really sort of better describe the tumor morphology and as and also definitely correlate with the long-term outcome.
Okay, I really want to thank you for that extensive presentation, and thank you for answering all the questions. I'm sure you'll probably be getting more as you are a to-go person at Sunnybrook and beyond it, I think provincially and nationally. So we'll continue with the meeting.